Good evening. It's a pleasure to be a part of this Fellows course of IPCI 2025 at Hyderabad. From DC Hospital, Cochin, we are presenting a case of OCT guided PCI in a case of acute coronary syndrome. Today, I am joined by my colleagues, Dr. Anish, Dr. Vijin, Mr. Anu, our senior cath lab technician, Mr. Joshi, who is handling the OCT, Sister Ivy, and Sister Angela. This 57-year-old gentleman had an acute coronary syndrome. Yesterday, he had 20 minutes of rest angina. He was hemodynamically stable in sinus rhythm at the time of presentation. His electrocardiogram showed a transient ST elevation which reverted spontaneously, and he remained asymptomatic afterwards. His echocardiogram revealed apical IVUS hypokinetic, and rest of the LV was normal with good LV systolic function. Let's have a look at the angiogram.
So we thought of an imaging guided PCI, the optical coherence tomography in this patient. So now we are going for the co-registration. Can we shift to the OCT images? We'll show the OCT images from the workstation. This is the OCT image. Chairpersons, would you like to interpret?
Yeah, obviously. This is the morphology that you're seeing, and you see the good EL there now. Oh, wow. Now, I think you should stop over there if it's possible, and then get that, because it's too fast for everybody to see that. Get to the area of interest.
Area of interest.
Go back. Go back.
Here.
Go back.
Go
back.
Go.
Wait, stop there. And now you click the co-registration on top. So you can see also at which part of the coronary artery you are on. Great. So you're at that part. See, that's where the lesion is. And now you see very clearly that you've got a intima that's torn off, and below the intima you most probably have got a nice cavity. So this is an acute coronary syndrome with either rupture plaque, and that's healed.
One thing is we may not require any aggressive lesion preparation. The fibrotic component is much less. It's mostly lipid rich, and there is no much thrombus, so a slow flow chance is less likely. Yeah, you can pause. Okay, Dr. Goniko, you can go ahead with the discussion. You can go ahead with the discussion.
Here, that's it. I mean, it's
right. The most important thing in acute coronary syndrome for an imaging is to find out. So this is, you can see the co-registration. So these are the landmarks. So in acute coronary syndrome, what we are looking at is what is the mechanism and what is the morphology of the lesion. What is the mechanism of acute coronary syndrome? What is the morphology of the lesion? And morphology is the most important thing. As Dr. Rani was showing, the ultron A can right now tell only about the calcification, not about the lipid component. The ultron 3 will be telling about the component of the lipid component. So you have seen the classical plaque rupture in this view, the classical previous one. The classical plaque rupture, you can see it's mostly, it's the lipid-rich area, and inside the lipid-rich plaque, you can see the cavity, and the integrity of the fibrous cap is lost. You can clearly see the loss of the fibrous cap integrity or of the broken fibrous cap. This is the classical plaque rupture, and it's a lipid-rich plaque. There is some amount of fibrosis, but the fibrotic component is much less when you look at the predominant lipid part. There are some small islands of the calcium also. Now, the second part of the evaluation is the length and the diameter. So this is one Dr. Rani was showing. The machine itself is telling, the ultron toe is telling what is the distal diameter, what is the proximal one, the EL. The EL of the proximal, go to the automatic one. Yes. This is the AI detected thing, that is the EL of the proximal vessel is 4.72, more than 180 degree arc, it can detect the EL. And the lumen is 3.68. And the distal reference is 3.94 and 3.34. So it is between the proximal is somewhere close to 4.7 and the distal is close to 4. Next. And the length of the lesion, what we have measured, what we are looking at is whether we can see the triple layer architecture of the vessel wall at the distal edge. It's close, as much as close as possible to the triple layer architecture preservation. And second thing is, what's the amount of plaque burden at that area? If possible, no plaque. Even if there are no plaque free areas, the minimal plaque area. So we looked at it and calculated a distance of 14 millimeter and close to 15 millimeter. So it is 4, that is EL to EL, and 4.7 again EL to EL. So we decided on a 3.5 15 millimeter stent, since it is a
Could we interrupt you, Jabir, at time? Do you mind that?
No. Please go ahead. We need a discussion. That's
Right. So it's very important, what he just said. Now, the landing zone, we always say that you need less of plaque burden. But remember, OCD doesn't calculate the plaque burden.
Yes.
That's for the IVUS to do. Because you really, if you've got a plaque, you really can't see the EL behind that in most cases. The EL is detected over 180 degree arc. You presume the plaque burden. So the plaque burden really is not an entity that we should be talking in an OCD.
Yeah, right. I fully agree with the plaque burden is calculated by the IVUS, and there the guideline is less than 50% of the plaque at the landing zone. So a reasonable landing zone we have identified and calculated the stent length size of 15 millimeter and the size of 3.5, and then we decided on a post dilatation by a 4 millimeter balloon at the proximal part. It is close to the septal. Is it okay?
Yes.
It's moving a bit. This is 3.5 15. This is the beginning. Is it okay?
Yes.
It's moving a bit. This is 3.5 15. You can see angiographically the proximal part is okay, distal there is little negative. Go. This is a 4 millimeter balloon. We post dilated with a 4 millimeter balloon and took another run of OCT. Go. This is the second run of OCT after post dilatation with a only the proximal part of the stent was post dilated with a 4 millimeter balloon.
May I co-register it, please?
And now you can see the automatic detection, the ultra-intrusive automatic detection. You can see some amount of under expansion. That also depends upon what modality you are using or fed into your computer. If this is a tapered modality of measuring the under expansion, and there is that orange is showing under expansion. Had it been a yellow, it is malapposition. There is no area of malapposition, but it's under expansion at some part, and you can see even somewhere it is close to 70%. Anything
So
more?
it's also important to say in this interface, that expansion is looking at orange is depending on what you have set on the interface. So you can go and change that. For example, can you just show that how you can go and change that on the case setting? Yeah, good, great. So you can go in there and change. Now, for example, here, let us put the expansion threshold as 90%. 90%. So now apply that. In that case, now it goes and now you will be able, it'll tell you only expansion that's
Except for apart from the edges, the proximal and the distal, it's all under expanded. It's all orange line now. The edges, it is more than 90% expanded, so there is no color marking or color coding. So at this point, we thought it's better to post-dilate again with a 3.5 millimeter balloon at the mid part where there is maximum under expansion. And it did have an OCT, and go to the OCT. This is 3.5.
Under expansion is acceptable.
See, Illumin 3 used 90%, and but I think what's accepted now most is 80%. But it's very important to understand also that in most of these trials, an expansion criterion of 80 or 90 was reached only in 40 or 50% of cases. I think you're not going to be able to reach a 90% expansion in most cases.
Does it have a clinical significance?
Absolutely. Expansion is everything. In fact, I think MACE is not dependent so much on apposition. It's all dependent on expansion. And as you said, that for every millimeter square that you can get, you cut down your MACE significantly.
Which is more important, is the percentage expansion or the absolute MSA you achieve?
See, absolute MSA is important, and that's why you always said it must be greater than 4.5. But you must remember that in India, we have small coronaries. In a small coronary, now if you take a 3 millimeter coronary, if you go by pi r square, that's I think 7.1 millimeter square. You're not going to be able to achieve that in all patients. So I think expansion will tell you very large, especially more than 3 millimeter, 3.5 millimeter vessels, expansion is more important. In smaller vessels, expansion is more important. Dr. Akasaka, what's your viewpoint on that?
Yes, generally speaking, 90% is the ideal expansion. But we have to think about the plaque eccentricity at the same time. Because if you dilate bigger balloon, right, the vessel is dilated to the normal side. Therefore, if there are very thick calcium and eccentric calcium, we have to think about the final result. At that time, we have to accept 80%. That is a clinical practice.
And if you see here, there is an interesting thing. Look, they were discussing, what is the absolute MSA? Here the absolute MSA at the tightest point, 74% expansion is 7.72. That the vessel is very big. But at the same time, you can see that that orange marking is coming down. Now there is only one particular spot you have the orange margin with a 73% under expansion. So here I decided on going with a 3.75 millimeter balloon and expand it again. Whether it is right or wrong, I am not, it's subject to your discussion.
But again here, see, you use a 3.5. So you use a 3.5. Actually, you must get how much millimeter square? Around 9.1. But remember, because 3.5 should give you a 9.1 millimeter square. But you're reaching only 7.5. And obviously, the expansion is less. So if you go by the absolute criterion, you've done a good job. But if you go by the relative criterion, you've done a bad job.
If you look at the data, I think the MACE is correlated with the MSA more than the percentage of expansion. And especially the calculated expansion can be flawed. when there's elliptical expansion, which is quite common in calcific lesions. Whereas the vessel expands more in one direction. So ultimately, what is more important is if you get an MSE of 7, even if it shows you 70% expansion, I think it's an excellent result if you have opposed it well.
Region, what is more important? Is the area of expansion is the MSA?
It depends on the case, but we have to, if you just treat just on the lumen profile, we sometimes miss the plaque distribution, right? If there are eccentric calcium plaque, it might be very difficult to dilate more. If you dilate based on the only the data of the lumen profile, you may have the rupture of the coronary artery. So at the same time, yes, AI is very important, I agree, and wonderful AI, but at the same time, we have to check the real image at the same time.
If we went ahead with the calculation with the elementary criteria, but when we used the Illumin criteria, there was no under expansion. That is dividing it into the two proximal and the distal part. There is no need to confuse you. I did the post dilatation and then went for the last shot.
Please, you have some questions.
Yes, sir. I just
The one
wanted to
question
ask-
to the, and there was a large diagonal.
Yeah,
that
I
was-
wanted to discuss that.
And there is, we have seen the thrombosis in the mouth of the.
Right, absolutely.
Does it not, we have to pre-dilate or something like that, so that you can protect the diagonal?
It's because of the lack of time that I didn't discuss. When we did the OCT, it was a lipid-rich plaque. There was no much thrombus. So we thought there was no need for any aggressive dilatation or aggressive preparation. And second thing is whether to protect that diagonal or not. When we looked at the diagonals, it was a 2 millimeter diagonal, and below that there are the same size or much bigger 2 diagonals down. So we thought it is better to go ahead with a direct stenting. So we didn't prepare the lesion, went ahead with a direct stenting. The diagonal got closed off. Then whether to chase the diagonal or not, there were no ST changes. Patient was absolutely comfortable, and the diagonal was opening up. It's a plaque shift or a thrombus shift. So we thought that it may open up in due course. So we left. We didn't chase that diagonal also. It's all because of the imaging that we thought there was no need for any aggressive preparation, and slow flow will be less because we did multiple dilatations with high pressure balloon, the last OCT.
Girish.
Dr. Jabir, one last question, chasing the apposition or the lumen gain in an ACS, I think it's very important to look at tissue prolapse, slow flows. I think the apposition and MSA in ACS is slightly different from MSA in every other situation. Your comment on that?
I entirely agree with you.
I also agree because in the setting of acute coronary syndrome, especially when it's a very recent acute coronary syndrome, the vessel will be usually maybe having some amount of spasm. So what we are seeing as a smaller vessel, but the real caliber of the vessel may be a little higher vessel. Here we went ahead with multiple dilatations and went for an optimal dilatation because we were sure that it is most likely the slow flow will be less because of the lack of thrombus burden in that particular lesion.
Thank you. I mean, my experience when I chased in the early days, I would have a lot more tissue coming into it and the MSA would never increase. Your stent may look expanded, but the lumen area is much smaller. I think taking a not very aggressive high pressure balloons, longer, steady expansion for a longer duration and come back may be a better thing.
Yes, Girish, I fully agree with you. This is the final result. There is no under expansion now. It's a proximal LAD big vessel. So an optimal
Absolutely.
result, I think it is essential.
Thank you.
Thank you.
So one last question regarding the sizing of the stent. He undersized when EL to EL, but in this case it was proximally 4.5 and distally almost 4. So yet you 4.2 I believe, but yet you chose to go ahead with 3.5. When you have a intravascular imaging, can be a little, can we go on to what is undersizing? Quarter undersize is more than enough, I believe. No?
It's EL to EL, so we always go with the distal vessel size.
So, but
The distal vessel size was 3.9 EL to EL. So the closest downsizing is 3.5.
Again, I think you should be very prudent about this thought process because you must understand in some platforms, a 3 millimeter stent and a 4.5 millimeter stent is exactly the same. It's just mounted on different balloons. So you can put a 3 millimeter balloon or a 3.5 balloon. What matters is what is your final balloon dilatation size. So it's not necessary that you get you've got to have to go with a 4 millimeter stent when you've got a 4.2 EL. You can go with a 3.5, but eventually go to a 4 millimeter balloon.
And this was the guided mode. And when we looked at the flexible mode, it was close to 3.7, only the size was little less.
Right. Thank you very much, Jabir. I think that was an excellent ACS case.